Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, with another of our Facebook Live events. It's the 26th of January. Time is flying. And this is another Facebook Live chance for you to ask questions. We'll try and get through them as many as we can. We've had some people send in questions at Facebook questions at douglaspublichealthnetwork.org. So if you want to get a question and be sure it gets answered, just put it on the website and we'll get to it. We'll get to as many of the online questions as we can. We really do need to leave by 7 tonight, so we'll leave at that time. I will tell you that in addition to our time on Friday at 4 o'clock, we're also going to be on KLCC at 3 or 3:30 on Friday, talking also about, guess what, COVID. Anyway, so let's go through where we're at. As always, we start at the world level and then move down. And so we started at the world level and then moved down, but we'll leave plenty of time for questions. So still a very active pandemic in the world. We went past 100 million cases in the world. 100 million cases is a lot. You know, the flu pandemic in 1918 was certainly more, with several hundred million cases in a world which was much smaller. So this, in terms of number of cases, is lower, but still really quite the active pandemic. We're at 2.1 million deaths. In the U.S., we're at 26 million cases. I mean, that's just an astounding number in the U.S. and about a quarter of the world's cases. And our total deaths are now at 435,000. We seem to just blow past 400,000 and moving up. 4,000 deaths yesterday. So really just a huge number of deaths that we're seeing in this country still. If you look in the world, the disease is still very active in parts of Europe, especially Portugal, Spain, and England. Very, very, very potent in Israel. And then South America continues to have a lot of cases. Asia, again, tends to be pretty quiet. Australia, Japan, South Korea, New Zealand, although they occasionally come up with new cases. We're talking about in Australia 20 cases in a day. Well, we have 20 cases a day sometimes in one Oregon county, so really is a tale of two places. In the U.S., the disease is still very active in South Carolina, Rhode Island, and New York, all very different places. Still very active in Arizona and active in California, although decreasing, and they've opened up some things again. In Oregon, it's been quiet. We've actually had a couple of days under 1,000, which has been great, although we continue to see new cases. In Douglas County, we are staying low. We're not in the extreme range. We're just in the high range as we were before, so businesses and restaurants and gyms can be open, although at reduced capacities. So that is incredibly good to hear, although we've just cut that by the skin of our teeth. We had to be under 200 cases per 100,000. We were at 196. That is way too close for comfort. I had an uncomfortable night on Saturday night, wondering how many cases were going to come in between 9 and midnight. It was that close to going into the extreme range. We did have some more deaths this weekend, and some really tragic deaths. I can't give you the details, but just heart-rending stories. In terms of the vaccine, that's probably the big deal, and variants is the big deal. So let me get to the questions here and see what questions you have. And again, please put them in the chat section here. Looking to see. Here we go. All right. So the first question we have here is about an article that says it's not safe to go to the grocery store with the new variant spreading. And the story is, it's not, remember, we've never declared anything as totally safe or totally risky. I mean, there's clearly a variation along the way. If we have a disease which is more contagious, it's more dangerous to do anything that you do before. So if it was dangerous to go to a birthday party, it's now more dangerous. If it was dangerous to go to a grocery store before, it's now more dangerous to go to the grocery store. And so that's where I would put it. How much more dangerous? I don't know, these new variants are said to be anywhere between 30 and 70% more contagious, and anywhere from not any more deadly to more deadly. This is already a very contagious and very deadly disease. So it is really not good news to have something that's more contagious and more deadly. So is it safe to go to the grocery store? Grocery stores have always been pretty safe. Big open areas, you can wear your mask, you can stay away from people who are not wearing masks. Excellent ventilation, and the contacts you have with people are going to be really momentary. Again, very different from other things like a sleepover or a party at your house where you may be all in the very same space for many hours at a time. So, next question is, Michael says, I'm 70 years old and have verifiable underlying health conditions. When would I be eligible for my first vaccine, and how do I sign up? And Susan asked the same question. So there's lots of questions there. So Oregon and CDC have come up with a strategy for prioritizing vaccine. There are obviously more people now who want vaccine than we have vaccine. And Oregon has made the CDC started with the prioritization, and Oregon has followed up with that. The 1A group, both the CDC and the state says, healthcare workers, EMS, and people in nursing homes and memory care facilities. We're mostly through, I think, that 1A group. The 1B group is going to be essential workers and people over the age of 75. Oregon has categorized teachers and childcare workers as essential workers and put them on the front of the list. They start this week with vaccines. I just moved late because I was sending the emails out to people who are doing this about how to sign up for the vaccines for teachers, educators, and childcare. People over 80 are going to start on February 8th. And so they'll start on February 8th. We're going to go through the 80-year-olds. It'll take a week or two, and then go to 75-year-olds and then 70-year-olds. So that if you're 70, you would be in that group of 70-year-olds. What we're hoping, again, we don't know how much vaccine or what's going to work. We're hoping that most people, most seniors, are not going to have to go to these big events and wait in long lines. What we're hoping is that when the time comes that your doctor will have the vaccine, and you'll be able to go to your doctor to get the vaccine. We have 42, maybe 44 vaccinators now in Douglas County, all over the county, people all over the county who can go ahead and give the vaccine as long as we have it. What happens is the vaccine comes into the county and we distribute it to those different vaccines. We're going to do a distribution on Thursday, and that's how they do it. And so when the time comes, and we'll do for all of these groups 1 week before their time. So we started with teachers. We started talking with the Education Service District last week. This week we're going to start doing teachers. The vaccine just arrived, and so we're going to do an event for teachers and other childcare people on Saturday at the fairgrounds. And then ESD is going to distribute the rest of the vaccine to the eligible groups. For seniors, again, we're not going to know about the allocations until the week before February 7th, and when that comes, we'll let people know. Again, our hope is that most people can get this vaccine at their doctor's office, where there's not a big sign-up. You know, you call a doctor and say, hey, I'm one of your patients, I'm 82 years old, and they say, great, why don't you come in next Tuesday at noon and we'll do your vaccine. Not a lot of big sign-ups and wait lists and whatever. It's just like you get the rest of your health care. If you need to get a B12 shot, if you need to get a flu shot, if you need to get a CBC, you'd call your doctor and get it that way, and that's what we're working. So, lots of questions here, but please clarify the impact and the effectiveness of the booster shot timing. So what happened was Moderna and Pfizer, when they were doing this vaccine, they recognized early on that you got a good response with the first dose and a better response with the second dose. And they wanted to get their vaccine trials done as quickly as possible. So what they did in the trials is Pfizer set a 3-week between the first and the second dose, and Moderna set a 4-week between the first and the second dose. And what they found was they got good response after the first dose. If you look at 14 days after the first dose, about an 80% effectiveness. And then after the second dose, about 90 to 95% effectiveness. Similarly with Moderna, you had not much effect in the first week, which would be as expected. And then after 14 days, about 80%, and then you went over 90 with the second dose. So we don't know specifically about that. We know lots about other vaccines, and delaying the booster dose makes no difference at all. And so, I'm a pediatrician, we give shots every day, that's what we do. And, you have the recommended interval from the first dose to the second. You shouldn't go sooner than that, but going later than that is no problem at all. We don't even think about it or worry about it, because if in pediatrics we were so obsessed with 21 days or 28 days, we'd never get done with our day. And we realize it doesn't make a big difference. I think this would be the same here. I think that, I think the story is people should get the first shot. And if we decide that we're still doing second shots, they should get the second shot, not shorter than the 3 weeks for Pfizer or the 4 weeks for Moderna. But how long it is, I don't think it really makes a big difference. Now, because Pfizer and Moderna wanted to get their studies done quickly, and they really did, they studied them only at the 23 and the 21 and 28 days. So we don't have data there, but there's nothing to suggest that going out longer is going to be a big issue. For example, the CDC said you could go up to 6 weeks. And there are a lot of people out there that think you could go into 6 months and do it. In fact, some countries have chosen that. So Israel and the UK have both chosen to delay the second dose so they can get more doses into more first doses into people. Really complicated discussion. No place in the United States has changed on that. Okay, so our Douglas County updates indicates we're potentially moving into vaccinating phase 1B individuals. That's exactly right. So starting this Saturday, we're going to do a big event at the fairgrounds for 800 people, and we're going to do that. So has Douglas County completed, for the most part, vaccinations on our 1A group? I think so. So we've reached out to many of the groups in the 1A. We've had for 4 weeks now a place that people in 1A can sign up for a vaccine. Somebody monitors that box every day, and last we checked, there were just dwindling numbers in that box. Still occasional, and we're going to get to them, but still occasional, so we think we're most of the way through 1A. What we don't know is people in 1A who haven't written to us, so maybe there are people who've not read the updates, haven't watched this, haven't read the newspaper, haven't listened to the radio, and don't know how to sign up, and so that's a possibility. The other thing we don't know is how many people have gotten the message and say, well, I don't want that darn vaccine, and don't call me, so we don't know. But we think we are most of the way through 1A. So the update also indicates that 1B folks are eligible, and would imagine there's some educators and associate folks to be in the next line, and yes, they were. So today we send out that note, and people can sign up tomorrow night for this thing that's going to happen on Saturday, and we're going to give 800. We also question about the risk level. So yes, in the risk level, we're still at the same high range. So again, we're one of the lowest big counties in the state. We are the lowest big county in the state, and we're one of the lowest big counties in the country, so we remain in the high range. In addition to the risk levels, there was a little bit of change on outdoor gatherings, recognizing that, and you've heard this now for 10 months straight, outdoor gatherings are at least an order of magnitude safer than indoor events. So I think there's a little bit more relaxation of outdoor rules, again, to have people go outdoors, because again, we think outdoors is so much safer. So my mother is in her 80s and can't find info on getting on the vaccine list. So again, our plan for seniors is we don't think there should be a big list and sign up. My mom back in Virginia said she was on the phone for hours, and they said, sure, you're signed up, but didn't know what that means. That is not the way to do it. The way is when the vaccine comes out, your provider should have it, and you could call them up and say, when can I come in for my shot? And they'll come in and get you your shot. So Linda says, can you explain why they're saying we need to double mask? Yeah, there was this thing this week about double masking. And the story is that the more barrier you have between your spit and the stuff that's coming in, the less likely you are to get infected. And there was this big deal about double masking this week. I think the biggest advantage you get is from people who do this for masking or this for masking, to actually put the mask over their nose or to use a mask. And I still go to stores where there are people not using masks. So that would be it. Now, if you really want to be safe, you should use and I didn't bring it with me, a KN95 mask. Or a KN95 masks really do a lot of protection. and you'll see it. But basically the story is if you can smell what's going on in the room, the mask probably isn't working that great. So if you could upgrade your mask, I'd upgrade to a KN95 or an N95 if people want to use double masks. I'm not going to stop people, but I don't think it's going to be a big issue. So Deanna says, is there a tier for autoimmune disorders? No. So at least in Oregon, there's no tier for underlying conditions. If you're 83 and perfectly healthy, you come before a 78-year-old who's got a lot of underlying conditions. I think many states are doing that because underlying conditions are so devilishly hard to figure out. I can figure out your age by looking at your license or some ID to figure out whether your autoimmune disease, Hashimoto's thyroiditis versus lupus versus active cancer or whatever is more of a risk factor is devilishly hard, right? We're not going to be able to look at everybody's health records. So I think in Oregon, they're going strictly by age. So Niall says, I'm an unpaid caregiver for my mom. Can I get the vaccine? A very complicated question. Again, what I would have you do is look at the Phase 1A sequencing guidelines. They have lots of clarifying information. So if you're a caregiver for your mom and she fits in one of the populations, then the answer is yes. If you're a caregiver for your mom and she doesn't, then the answer is no. And that's why I'd have you carefully do it. So Joanne says, what's the production level of the various vaccines? So the two vaccines that have been approved have been the Pfizer vaccine and the Moderna vaccine. Both Pfizer and Moderna, we are expected to get about 200 million doses of both from them. So 400 million doses total, 2 doses each, 200 million people by the end of the summer. So if we're just on Pfizer and Moderna, we're not going to get to herd immunity until way past that. You know, the hope is that there'll be new vaccines coming. There's the AstraZeneca vaccine, there's the J&J vaccine, there's the Novavax vaccine, 3 other vaccine candidates that are there. And certainly if they brought it up, we would do better. These vaccines are really hard to make. I mean, these are mRNA vaccines. So basically what you have to do is you have to get the RNA of the virus. You then have to make a copy of that, and then you have to snip it into the mRNA fragments to do it. Now, these things are absolutely microscopic in size, so it's not like somebody sitting there with a pair of scissors. You have to use very special enzymes to get it in this. So they're really hard to know, hard to do. So I think both of those companies are working as fast as they can. Moderna, most of the vaccines will come to the U.S., but Pfizer is a multinational company. The company that's making it is BioNTech, making it in Europe, and they're supplying not just the U.S., but they're supplying lots of different people with the vaccine. So, the U.S. is just getting a tiny fraction of the Pfizer vaccine, and so, I mean, Pfizer and BioNTech are working as fast as they can, but the vaccine production is not nearly as much as we would like. So does the vaccine actually give you immunity or make you less symptomatic? We think it gives you immunity. We clearly think it makes you less symptomatic. The question is, can you still have an asymptomatic infection after? Maybe. I mean, the studies were not designed to look at that. They are doing studies, especially in Israel, where they're looking at antibody levels afterwards. So we'll see if there were lots of asymptomatic infections. But I think it's probably not all that important. We think that the people who are most contagious are people who are symptomatic and pre-symptomatic. And yes, it stops both of those things, which are the pre-symptomatic and the symptomatic phases. So Jennifer says, have Reed Sport teachers started getting the vaccine yet? I just got an email, and they started this week. So they're starting to get their vaccine because it's a long way to ask people from Reedsport to come to Roseburg, and because Lower Umpqua Hospital had some vaccine, Lower Umpqua Hospital is doing the people in Reedsport. So Veronica says, what about wearing a mask after you're vaccinated? Absolutely. I mean, these vaccines are not 100% protective, and so I would go ahead and wear a mask. I mean, again, all of these things that we do, getting vaccinated, socially distancing, wearing a mask, each of these sequentially decrease your risk of getting the virus. And so this is really a belts and suspenders approach. you want to wear a mask, you want to socially distance, you want to stay home when you're sick, and you want to get the vaccine. So we'll do that. Linda says, is there a charge for the vaccine? So the story on the vaccine is the vaccine was all purchased by the federal government with the CARES money, and so we've basically already paid for that with our taxes. There is an administration fee for the vaccine, but the patient should never see that. If you don't have insurance, there's another government fund to pay for it. So you should never see a charge for it. Although, if you look, for example, in your medical record, saw was ever charged for the vaccine, there was. Now, some of that is because charges in American medicine translates into your health care. It's sort of weird, but it's sort of the way that we can enter into the record that you got this vaccine. And so, yes, there's a charge. It's only $16, I think, is what Medicare is paying for administration of this dose. So it's not a whole lot of money, but there's no charge to the person getting the vaccine. So what's the status on the J&J vaccine? So the J&J vaccine is a weakened human adenoviral vaccine. The J&J vaccine, they say, is close. What I've seen is it works in animals, but when things work in animals, they don't always work in humans. And there are good levels of neutralizing antibodies, which suggest it should work. It is not yet up for approval. Basically, they need to be 2 months after the people get their first dose to look for safety concerns, and we're not there yet. We think it's probably going to be in the next month. So, I don't know who said, how do we know if we're on the list? Who controls the list? I don't know what list you're talking about. So if you could write in and tell what list you're talking about. So Ralph said, OHA just sent me an email not to call my doctor's office to get signed up when it's my turn. I'm confused now and like, no. So not to call your doctor's office now because your doctor's office doesn't know, certainly more than I do, about how and when we're going to get the vaccine and how much we're going to get. But when we know how and when and how much we're going to get, we will send out a message that, like Dr. such and such's office has it. If you are a patient of Dr. such and such, please give them a call. If you're not a doctor, then we'll figure out how those people who don't have regular doctors do. But again, if you're 80 and you don't have a regular doctor, there's a real problem there. I mean, everybody, I think by the time you're 60, should get a regular doctor who follows you. So Ryan says, is bowling safe? Well, there's nothing particular about, I don't think there's anything particular about bowling which would make it safe or unsafe. Really what it is what you're doing when you're bowling. So if I was in there on lane 23 bowling all by myself with nobody else around wearing a mask, that would be pretty darn safe. If the story would be typical of the times we've gone bowling, and I'm one of the world's worst bowlers, where 8 people sit around, you drink beers and chat with people about what goes on, you high-five people when they get done, there's a lot of shouting and whatever. That isn't safe. I mean, that really isn't safe. And so it's not bowling itself, it's the things that go around bowling. And again, the things that make something safe or not safe is indoors versus outdoors. Outdoors much safer than indoors. Bowling is almost always indoors. The second is how many other people are you going to be around? And the story is if you're bowling by yourself on lane 23, not very many. If you're in a group of 8, there's a lot. And then what's the duration of the contact? Again, if there's no contact, it does make a difference on the duration. But typically when you bowl for an hour. So that's a fairly long, fairly close. And because there's a lot of eating and drinking involved, a lot of unmasked activity. So I think the typical way that my family would previously have gone bowling with a bunch of other kids, I would say is one of the less safe activities. So where you are on the priority list. So the priority list in Oregon has only so far been the 1A group has been defined. The 1B group, the only part of that's been defined has been educators. And then the governor's made an announcement about people 80 and above. That's all. You'll have to look on the Oregon Health Authority website under the sequencing plan. So how can our public school system be safe to reopen? Well, so again, remember, we never say that anything is totally safe or totally dangerous. Schools do a really good job with their spacing. They do a really good job with wearing masks. They really worked a lot on the ventilation in the schools. And so schools tend to be relatively lower risk than other activities. In addition, kids less than 10 probably get and transmit the disease less than those who are older or adults. And so, it's a calculated risk when you open schools, just like it's a calculated risk to go bowling, to go shopping, to go to a restaurant. All of those are calculated risks. In the whole scheme of things, we've not seen a lot of transmission at schools, although we currently have 10 schools that have a case or more. So there's a lot of work going in and tracking those down, be sure there's not another case. It's really maddening about what's going on there. So it's hard. In terms of buses are another, to some risk there. They are spacing kids at least 1 meter apart, so that decreases the risk there. But, we know in Douglas County there's some kids who travel long ways on buses, so there's some risk associated with all of that, although I think it probably is a reasonable risk given the many benefits of school, right? So when in medicine there's this concept of risk and benefit. And so you certainly want to do things where the benefit is greater than the risk. And so years ago when we always treated appendicitis with surgery, the risk of having the operation is, the risk of anesthesia, you could get infection, whatever else. But the benefit is that you won't die of appendicitis. And so almost everybody, when they had appendicitis, they'd say, well, here, I'm going to explain the risks and benefits. What do you want to do? Almost everybody said, well, go ahead and take the darn appendix out. And so there's a risk and benefit to everything. And so, there's a risk associated with going to school, but the benefit from school is that this is where kids learn, this is where kids socialize, this is where kids grow. We've certainly seen a lot of mental health issues from kids who've been cooped up at home. So it helps with the mental health. It helps with many kids who get fed there, many kids who learn there, many kids who socialize there. And then there's the risk, but again, that risk is pretty small. Well, compare this to something else. Let's say bowling league. And Brian, I don't want to pick on bowling league, but let's pick on bowling league. So somebody says, hey, there's a bunch of us here. Let's go bowling tonight. And we're going to be 6 there at the lane, and we'll sit around and we'll drink beer and shoot the breeze about what's going on. That the risk of that is certainly more than school, because at school they're distanced, they're wearing masks, lower risk of transmission. Here, we're going to be bowling and eating and drinking, so not wearing masks. We'll be closer together. They'll be yelling and shouting, all of those things that would happen. And what's the benefit of bowling? Well, it'd be seeing my friends. So again, if I had to weigh that risk and the benefit, I would say the risk is not worth the benefit. Let's do this when COVID is done. Others may say, hey, that bowling is so critical for me, I just got to do it. And I don't see the risk as being that high, and they may decide to do it. And that's why when we look at the risk tolerance, people's risk tolerance is unpredictable. Some people have far higher risk tolerances than others. But again, if I had to say the benefit of opening schools is great, the risk is not zero, but it's fairly small. So I think it does favor opening schools. So when will the number of vaccinated people start to affect the county matrix calculations so businesses can stay open? So for people who are nerds out there, there's what's called a basic reproductive number of a disease. So one person, if you do nothing, how many people do they give it to? So with the original variations of COVID, it was between 3 and 4, so we used like 3.2 as the number. This new one, which is 50% more effective, is 4.8. So you decrease this by using things like masks and socially distancing. So you can use masks and socially distancing and bring the R from 3.2 down to less than 1. So we know that, for example, in New York City, it was well over 3. When they did their lockdown, it went to under 1, and the disease went down. You can also do that by other things like vaccination, and so those things are additive. So, for example, if we decrease the contagiousness of this disease by 50% by wearing masks and social distancing, and then to decrease more further by vaccination, we could easily get the R under 1, and the disease would, over the space of a few weeks, go away. So both masking, distancing, other public health measures, plus vaccine are additive in their way to do it. I think if people are careful about masking for the next 100 days, 150 days or so, and vaccine gets out there in the next 100, 150 days, the R of this will be less than 1 and the disease will go away if the variant doesn't become widespread. Sadly, if the variant becomes widespread and the R goes from 3 or 3.5 to 4 or 4.5, it means that many more people have to get vaccinated, and we'll have to get much stricter about masking. So we're really, 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 really hoping that that it's going to work. Now, I do not think the number of people vaccinated by itself is going to affect the matrix. I think you're going to look for the result of people being vaccinated, which is decreasing case rate, to affect the matrix. So Amy says, do we know if the vaccine is at all effective against the new strains? And the answer is we think yes. So we've been anticipating variant strains for a while. So this is a great study about 6 months ago. I don't think we ever talked about it because it was only interesting to scientists at the time. And basically what they did is they took another coronavirus. It wasn't this one. They took a different coronavirus and they ran it through mutations. And they looked to see then what happened with antibodies to this mutated thing. And they found that typically when people made antibodies to the virus, they made lots of different antibodies. What would happen is that as the virus mutated, certain of those antibodies would no longer work, but others would. And they really couldn't make enough mutations so that none of the antibodies worked. And I think that's what we're seeing now. So I think we're seeing in the strains that many of the antibodies still work and it's still likely to be effective, but that maybe some of the antibodies you make will not be as effective, so that overall the vaccine may be slightly less effective, which then totally means we have to get rid of this now before those vaccine variants really spread. You know, those vaccine variants really spread. That's going to be the biggest issue. I mean, it will be absolutely disheartening if, you know, we get everybody vaccinated and then find out these new variants have come and the vaccines don't work well. That's going to be really, really, really hard. What about those who live in Douglas County but their PCP is in Lane County? Yeah, we do not know about that yet because we have the other way around, where people live in Lane County and come down to Douglas County for care. We have not figured that out with Lane County, how they're going to do it. Their view on how they're going to do vaccines for the seniors is a little different, and so we have to work that out. But right, these 2 weeks we're working on seniors. So my mom was turned away for a vaccine last week for a vaccine because she had an anaphylactic reaction. Yeah, so there are anaphylactic reactions, about 1 in 10,000 or so, maybe less than that, but 1 in 10,000 or so with the Pfizer vaccine, maybe 1 in a couple, maybe 1 in 100,000 or so with the Moderna vaccine. So not very common, right? So we did 753 vaccinations at the fairgrounds last weekend. No reactions. They didn't even actually open the crash cards. So not that much. So the overall risk is low, but if you've had anaphylaxis, it's bad. You shouldn't be turned away because of that, although some places that are not really set up to do anaphylaxis would choose to have you do them at a place that is set up to do anaphylaxis. That's perfectly reasonable. The other thing is that people might want to wait for the AstraZeneca vaccine because the AstraZeneca vaccine is a live vaccine. We're not exactly sure what people are reacting to in this virus. It may be the fat covering on these vaccines. It might have something to do with the cold storage. There's no antibiotics in them, but we don't exactly know why people are reacting. We know that AstraZeneca vaccine is going to be an adenoviral vaccine. We don't think there should be any anaphylaxis with that, but the results from the safety data in J&J aren't in, and so we'll see. So what I tell people who've had allergic reactions is you want to be sure you get this in a place where they're set up to treat anaphylaxis. Anaphylaxis, when it happens, is pretty scary. It's this big acute allergic reaction that comes on. Sometimes you faint because your blood pressure goes down. You sometimes break out in hives. Sometimes you want to have trouble breathing. So my point is, if that happens, you really want to do it with somebody who doesn't panic, because I've seen this before. I know what's going on, but it doesn't mean you can't get the vaccine. So Linda says, is every positive case tested for the variant? Well, that's a great story. No, not even close. In the U.S., only about 1 in 300 viruses is tested for the variant. 1 in 300, that stinks. There are some places that are doing every one. So there's a lab in Denmark that's doing every positive they're testing for the variant. England tested a lot of their case for the variant. I've not been able to find the percent, but it was like 20% of the cases for the variant. In the U.S., it's 1 of 300 cases. That's awful. This happened. Let me give you the backstory, and this has not been well published, but this was the backstory. So usually what happens is genome variants are done by the CDC all the time. So when you hear about an outbreak of salmonella in this and that and the next thing, there's a zillion different kinds of salmonella. And what the CDC does is they fingerprint that, so they get really exactly what the germ is, and they can tell if these are all the same germs, and exactly the same germ, that they must have come from the same place. Because again, salmonella, like most germs, mutates. And if you just got 5 different salmonella strains, they're totally different. And so similarly, the CDC does that. Well, you'll remember the CDC lab got enormous crap for their PCR test. Remember, there was an issue with the PCR test, and the CDC lab has been totally sidelined. So in most worlds, the CDC lab would be doing this genomic testing, and states would be sending a bunch of specimens to the CDC lab. They would collect all the variants, and they would see these variants, and they would know. Well, the CDC lab has been totally sidelined. They're not set up to do it. So it's mostly now little labs that are doing it. And because of that, we have this really haphazard approach in the U.S. And I think we have no clue about how many variants are out there. There have been 3 so far in Oregon. But if you did 100% of the next 100, I would bet you'd find some. So that really is one of the areas we totally muffed. We should have recognized that these variants were coming, especially when that first one, the 614 variation came through. We should have recognized that there would be more variants, and especially variants in places where you had a lot of disease circulating. And not a shock when you look at where these have come from: UK, Brazil, mink farms, South Africa, and Southern California. I mean, they're not coming from places like Australia and New Zealand where there's no disease. They're coming from places where there's tons of disease. And really, in retrospect, we should have better anticipated this. They didn't ask me. So somebody says, what about face shields? Are they still okay? Masks better? Well, actually, the best is a mask plus a face shield. So you'll see in the hospital, that's what they use. Masks face shields protect other people reasonably well. They don't protect you very much, especially if the disease sticks in the air, because it can easily get up around that. So, the recommendation would be that you use a mask. Now, there's some people who absolutely can't use a mask, and the only thing they can wear is a face shield. Certainly better than nothing. So what if you test positive close to when you were supposed to get the vaccine? Is it still safe, or should you wait? So the story on that is that natural disease gives you about the same kind of protection you get from the vaccine. Maybe not quite as good, but right up there. So the recommendation is, if you've had the disease, you have some protection for the next 3 months. So you could maybe step back in line and let somebody who's not been exposed and is totally susceptible get the vaccine, and then in 3 months get the vaccine. So you certainly can get the vaccine at any point. So having had the disease is not a contraindication. It's just that with vaccine being in short supply, probably a 90-year-old needs it more than you who've just had the disease. All right, so well, she's coming up with more questions here. A couple of other things that we have come up with over the week. One is, people have remarked a couple of times why Douglas County's rate of immunizations looks so miserable when you look at that graph around the state. And, we've dug into it. We've known some of these things for a while, but there are two reasons here. At least two reasons, or maybe more. One of the reasons is that many of the vaccines in Douglas County have been given at the VA. Now, that graph that map you see there is about immunizations given by non-federal providers. So the VA is a federal provider, so they don't report to the state, but they report to the CDC, and the CDC has not yet reported back to the state. So all of those vaccines that have been done at the VA, and we think there have been at least several hundred so far, don't get put in there. The second is the vaccine distribution per capita in different counties varies widely. So early on, the state wanted to get big events so they get a lot of vaccines in quickly, and those were done in places like Jackson County, Lane County, Marion County, and Multnomah County this last week in Deschutes County. Something that should ring a bell. These are all big population areas, and so they get a lot more vaccine per capita than other areas. So we got about a third as many doses per 1,000 people as some of those other counties, and since we've gotten a third of the number of doses, obviously our numbers can't look as good. I mean, we've given almost all the vaccine we have here. We did an inventory today of how much vaccine is not yet given, and there's almost none. There are a couple, we're saving 700 doses for this weekend, so that's 700 doses. And then there's a bunch of doses which are going out to providers on Thursday to give on Saturday. So not like there's a lot of vaccine sitting on the shelf. So Alexander says, are neck gaiters a safe version of wearing a mask? It depends. The sheer neck gaiters, and I've seen some of these which are made out of lace, are not. This one my wife made, and has got multiple layers in it, so it's basically a mask built into the gaiter, and these are safer. So Sharon said, I'm disappointed that educators were given priority over elders. Why? How and why did that happen? Yeah, I think I probably answered this question a bunch of times this week. And so the big problem is there's not enough vaccine, right? And so you had to make a priority of who's going to get it first or second. And some places prioritized seniors and healthcare workers. So the Brits did that. Other countries and other states have prioritized ways. Florida has had just anybody over 65, anybody with an underlying condition, any healthcare workers, you just show up. I think that prioritized people who had cars who could sit in line for 14 hours. But why in Oregon, we could have prioritized 80-year-olds and then teachers, or teachers and then 80-year-olds, and the decision was made to prioritize teachers for 2 weeks over the 80-year-olds. And I think, I'm not sure, but I think it was because there was an incredibly strong desire to have schools reopen this school year. And if you'd done it the other way, where you did seniors first and then teachers, you would not have gotten to teachers until April or May. And if you didn't get to teachers until April or May, you may not have been able to open schools this year. And then this would have been almost an entire school year, plus some of last year, that kids missed. And I think there was an incredibly strong desire to open schools. And people who work in schools are a little bit at risk. Although I said schools do a good job with separation and whatever else, we're asking a teacher to be in the classroom, let's say it's fifth graders, with 20 fifth graders for hours every day. Everybody tries to wear a mask. Everybody tries to be safe, but they're fifth graders, and they probably throw spitballs if they're anything like I was. They probably shoot spitballs. They may laugh a lot. Somebody may cough or sneeze and spread it to others. And we're asking the teachers to be in the classroom with that. I mean, So it was a decision. Do you do teachers first, do you do that? And I can tell you, I don't ever want to be governor, because that kind of decision is an incredibly difficult decision to make. I mean, it's sort of like the house is burning, which kid do I get first? And I can clearly understand the arguments for doing seniors. They tend to get much sicker. They tend to die with this disease. I totally get that. But then I can also see the argument for teachers. We really, really want to open schools, and we're asking teachers to go into a dangerous area, and so we need to protect them. And so I can see both sides, and I hope other people can too. You had to do something. You had to make some decision. And I can definitely see the reasonableness of this decision. And as I said, I'm so glad I'm not governor that I had to make the decision. So Alexis says, my husband is a teacher. How does he sign up for the event this weekend? So ODE asked that we send the information to their employers, and that their employers should send the information to their employees. And so he is a teacher. He's employed by district or whatever else. I sent the emails out at 5:17 tonight to each of the schools, private schools, daycare centers, and emergency child care centers to send this to their employees. And so your husband may talk to his boss and say, hey, did you get that email? Now, I will tell you, I got about 20 of these returned because the emails that we got from the state appeared to be not in use. So again, you need to be able to talk to your boss and say, hey, give me the link. There's going to be a link. It's going to be an Eventbrite sign up. So if you've ever signed up for theater tickets or concert tickets or whatever, it's a big website. You get on their link, you answer a few questions, and then you do it. That link is not going to open up till tomorrow night at 5 o'clock. What I didn't want to do was to send it and say the link is there, and people who were lucky enough to check their emails tonight got in, and people didn't check their emails until tomorrow, which I will tell you is a far healthier thing. I think checking emails at night, which I've been known to do, is really not healthy for your psyche. So that's why we allowed some time for people to do it. So he's going to get it. He should get this link. He should sign up on Eventbrite. Now, we think there are probably going to be more teachers than spots on the Eventbrite. Our plan then after that is for ESD and Aviva are going to arrange clinics to catch up on the people that didn't get in this Saturday. But again, we don't think there's going to be enough vaccine. There's 4,400 people, probably maybe more, in that teacher group, and we're going to get 700 doses this week and 700 doses next week. Not nearly enough to go ahead and cover all those, and so I'm not sure what's going to happen there. Okay, one of the other things that, let's see, I've written a few things I want to talk to you about. One is about the Federal Pharmacy Partnership. So the Federal Pharmacy Partnership was a partnership between the feds and Walgreens and CVS to distribute vaccine to people in nursing homes. It has gone okay. The problem is we have no clue who they've given it to or who not. And so it's one of the clunky things that's gone on here. We think that many of our nursing homes have been vaccinated, but it's really, really hard to know because they're not good at sharing information with us. The other things that have come up in the next bit has been about protective equipment. Protective equipment is still in this country pretty scarce. You think almost a year into this that these factories would start gearing up and making the PPE. There was a great story that I saw today about why that hasn't happened. And the reason it hasn't happened is because producing these relatively low-tech items, N95 masks, gowns, and gloves, is much more costly in the U.S. than it is in Asia. And so gloves are a great idea here. They used to be made carefully in the United States, and they were very expensive. And then glove manufacturer moved to Indonesia and Malaysia, where it became now really cheap. So gloves that used to cost 10 cents a pair now before the pandemic cost a penny a pair. And hospitals, looking to cut costs, moved much of their purchase of PPE from the United States to overseas manufacturers where it was cheaper and was remarkably good quality. And so in the 90s, in the early 90s, almost all of the PPE in the United States was made in the United States. Between 1995 and 2012, almost all of that production went overseas. So it was something like 90% produced in the U.S. in 95, 10% produced in the U.S. by 2012. And it was hard because, if a hospital looked at a pair of gloves nearly equal, and they were 10 times more expensive, they then chose to do it, to buy these overseas. What happened in the beginning of this is those areas stopped exporting and kept production for themselves, and China especially kept production from themselves, and so there was this big shortage of PPE in the springtime. They said, oh my goodness, these American companies should do it. Well, by the time the American companies started getting going in May or June, the pandemic was already kind of over in China, and they started producing again and selling it back to the U.S. at prices which were much higher than it was before, but still lower than many of the American producers. And so people then continued to buy from China, and these American companies that wanted to ramp up and make new things didn't have much of a market. And this is where the Defense Production Act would be not unreasonable. So the Defense Production Act says to a company, look, let's work together on doing this. We're going to get this thing. We'll buy from you, or we'll arrange to buy from you masks at a price where you can afford to make them and make a little bit of a profit. Not a lot. And we're going to be sure that if you need a loan, we'll give you the loan and whatever. So it's sort of it's kind of a cooperative arrangement to do it. And we'll continue to buy those gloves from you or those masks from you for 3 years, so that the cost of all of this equipment that you got gets used up over time. That never really came to fruition. So we've really not used the Defense Production Act appropriately. And so what's happened now is these companies that really were interested in doing it really have not prospered. And so we could still, if we had a big need for PPE again, get short. And again, that is really disappointing. Now, there are a couple of bright spots. We got a very generous grant from Atrio. And we wanted especially to focus on an American manufacturer of goods. So we found this group up in Salem that previously made outdoor gear, kind of stuff that you might use for mountain climbing and whatever else. Well, obviously their business was down during the pandemic, and they retrofitted to make gowns. So we got this thing, and they made us 500 of the most gorgeous gowns. I mean, they sort of look like the finished product that you would. They look as nice as any gowns we've ever seen, and they made them at a somewhat reasonable price. They're reusable gowns, and they were $20 or so, and they're beautiful gowns, and we've done that. But again, that's a onesie twosie. That is really not bringing back this manufacture to the United States. And the concern is the next time we have a pandemic, again, we're going to be relying on other countries to go ahead and supply the PPE. So this is a big problem with American healthcare. American healthcare is very much profit-focused. Even not-for-profit hospitals clearly are really, really, really strict about what they spend for stuff, and if you say, I want to buy these gloves in the U.S., they're 3 or 4 times as much, but they're made in the U.S., that doesn't get you very far. And so that's some of the reason we're in the PPE problem we're in. Okay, well, that looks like the end of the questions. We do need to go by 7, so thank you all. Again, if you have questions, put them in at Facebook questions at DouglasPublicHealthNetwork.org. We're going to do this again on Friday at 4 o'clock. And we'll try and answer as many of your questions then. And then in addition, KLCC at 3 or 3:30 on Friday, I'll be on with Pat Ludke, who is not only one of the smartest guys, but he's got a great radio voice that I'm jealous of. Again, this is Dr. Bob Dannenhoffer. Be safe and be kind. Thanks. I think Brian's coming. I'll have to do the Ferris Bueller thing again. Oh, there he is. Okay, well, thank you guys. We'll do this again on Friday. Bye-bye.